a great interest in allergy, and some of them are already practicing core allergist, and many are, you can say, taking care of majority of the allergy patients. But majority will be pediatricians, but some will be from the general medicine and ENT colleagues also who are practicing allergies and gastroenterologist.
Perfect.
Dr. Shyam, good evening. Thank you for joining.
Very good evening. Very good evening. Hi, Dr. Mata. Hi, Dr.
Hi.
Good evening, Dr. Sham.
So at present we are live on YouTube and we will start in a minute time. Good evening, everyone. So today, once again, we are here, and I would like to invite all of you and thank you all of you for this yet another webinar, a special webinar on a very important topic, which is food protein-induced enterocolitis syndrome. As we all understand, we have heard this name called Fpies, but majority of us struggle to think about it, make the diagnosis, what are the differentials, and many a times management of a particular child. So it is like such a close mimicker of, you can say, like different other disorders, could be gastroenteritis, could be milk allergy. So many a times it is not diagnosed or it is not picked up timely, and then it may lead to very severe consequences also. So we are very fortunate that we have got two experts today to discuss about this very important issue. The first expert is from UK Imperial College. The detailed introduction will be given by Dr. Nandana. And so we are very thankful to Dr. Martha, who has joined us from Imperial College. And the second expert is from our own India. He is pediatric gastroenterologist, and he is Dr. Shyam Meena. So without much delay, I would like to invite today's moderator, and not only the moderator, actually the person behind everything for today. So Dr. Nandana Bala, she has actually arranged today's meeting, and I think she is the right fit to moderate today's session. So Dr. Nandana Bala is a senior consultant pediatrician and allergy specialist at Rainbow Children's Hospital at Bengaluru. She has been trained at UK under in Imperial College itself, and she has worked in United Kingdom for at several posts in the field of allergy. So I think she is a well-trained allergist. And Dr. Nandana, thank you very much for accepting our invitation. And you please take care of the session. Thank you.
Sure. Thank you. Thank you so much, Dr. Neeraj. And thank you so much for the kind introduction. Good evening, everybody, and a very warm welcome to you all. And my sincere thanks to the Indian Academy of Pediatrics Allergy and Clinical Immunology chapter, and Dr. Neeraj, our dear chairperson of the IAP Allergy chapter, for organizing this webinar on a very interesting and important topic of Fpies, food protein-induced enterocolitis syndrome. As we all know, IAP Allergy chapter has been conducting numerous educational sessions by national and international experts in the field of allergy and making the latest updates readily accessible to all of us clinicians. And we are so grateful for this vast pool of resources that we have. It is my very great pleasure to introduce the faculty for tonight's session, Dr. Marta and Dr. Shyam Meena. The speaker for tonight's session is Dr. Marta Vasquez Ortiz. Dr. Marta is a consultant in pediatric allergy at the Imperial College Healthcare and NHS Trust, and the course director of the various allergy courses at the Imperial College London, of which I am fortunate to have been an alumnus. And Dr. Marta is an internationally recognized clinical academician with a special interest in food allergy, particularly Fpies. She is the chief investigator of the BioFpies study, which happens to be the largest prospective Fpies cohort worldwide. And Dr. Marta is a global leader in the efforts to develop diagnostic and prognostic tools for this not so well understood condition. Dr. Marta has been the board member of pediatric section of the European Academy of Allergy and Clinical Immunology, the EACI, for many years now, and is a member of the EACI task force on various food allergy related guideline groups. Dr. Marta has published extensively on food allergies, particularly Fpies. So Dr. Mata, on behalf of the Indian Academy of Pediatrics Allergy Chapter, a very warm welcome to you, and thank you so much for agreeing to do this session for us. We are indeed quite honored to have you. We are also quite honored to have our expert panelist for today, Professor Shyam Meena, who is the professor and head of Department of Pediatric Gastroenterology, Hepatology and Nutrition at the Vardhman Mahavir Medical College and Safdarjung Hospital, New Delhi. Dr. Shyam, as we all know, is an accomplished researcher and has numerous publications and awards to his credit. A very warm welcome to you, Professor Shyam. And without much ado, I would like to hand over the stage to Dr. Mata. Over to you, and you can share your screen, please. Thank you so much.
Thank you so much, and it's an absolute pleasure to be here and share, some time talking about Fpies with you, which is of course quite close to my heart. Before we start with that, I discussed with Nandana that people might be interested in hearing a tiny bit about our allergy education program at Imperial. So I have a couple of slides on that, so just very, very quickly. So Imperial College London, we're very much based in central London, and Imperial is the top 2 university worldwide, which is quite remarkable, and again it's a testament to the quality and commitment of the entire community. So very much the faculty, the academics contributing to the education and the research, as well as the students in our programs that are really motivated and very hardworking and very engaged with their learning. And Imperial has done very substantial contributions in the field of allergy for many decades, and that's what allows us to have now world-class teaching with our program, with our MSc. We have world-leading experts as module leads. We have a very comprehensive syllabus covering all the different aspects of allergy and asthma, and it's very much student-centered, active learning, lots of learning by doing lots of discussion, lots of group work. We're a very flexible program. We are part-time. Most of our students are busy healthcare professionals already working in allergy, wanting to know the latest and the best evidence for their practice. And we have an online stream that involves, following the full of your studies online, as well as a blended stream for those who want to come on campus for part of their studies. And it's very much an international flair. So we have students as well as faculty from all over the world, and very much of a global reach and global approach. So this is the structure of the program. So it's structured in 3 years, and people can choose to do 1 year and exit with postgraduate certificate, 2 years and exit with diploma, or do a full MSc, including the research project. And you see the different modules there, covering from the scientific basis of allergy, cutting edge of allergy, and all the different sort of disease areas: food allergy, asthma, rhinitis, skin and drug, pediatric allergy, etc. So quite comprehensive there. So I'm not going to go in detail about the module leads, but you probably recognize some of these faces, from conferences, etc. Some kind of world-leading experts like Steve Daram or Adnan Kustovic, Charles Aglani, Andy Bush, Prof. Tana, etc. So we're very privileged to have really sort of very motivated, very passionate faculty teaching the course and heavily involved in the course. So if you want to join us, so the deadline for applications is August for the online stream people, and for those wanting to join the blended stream is end of July because of visa requirements. The fees are there on the screen. Everybody says, it's not cheap. Imperial, second best university in the world, and UK universities is not cheap, but it's extremely good quality education. And we have funding opportunities with scholarships. So if you're interested, just go on the website and have a look, and feel free to approach with any questions there. So this is the little plug about the MSc, because Nandana mentioned that people might be interested, and I'm going to move on to Fpies. That's of course very, very keen on sharing sort of experience with you and joining the debate later on. So as Nandana very kindly said, so I'm a consultant in pediatric allergy with a specific interest in food allergy, and particularly Fpies. And this is what I'm going to be talking about today. I'm going to just give you a snapshot of what the BioFpies Research Network is about, to understand where some of the data I'm going to be presenting are coming from. And then we're going to go into what the community, the Fpies community, sees as their needs, the challenges, their unmet needs, And then we're going to go into very practical aspects of what we know and what the limitations are in terms of Fpies diagnosis and management, okay? And in Fpies, if you compare with other disease areas in allergy, like IgE-mediated allergy, the evidence base for many of the decisions we need to make is not that strong, and often you just have to do with the information you have. And that's a limitation, of course, despite the fact that publications have really sort of increased in the last 10 years. But at the same time, that opens the door for more shared decision making and individualized care, discussing, what we know, but also what we don't know, and then making decisions that suit our patients, okay? So it's going to be very practical, okay? I think I'm going to touch at the end on what we know about the biological mechanisms of Fpies and how BioFpies is contributing to that as well. So we set up the BioFpies network back in 2017 as a collaboration between Imperial Pediatric Allergy, with me as the lead there, and the Imperial Pediatric Infectious Diseases team that have done a lot of work looking for biomarkers, sort of omics-based biomarkers and diagnostic signatures for febrile illness in pediatrics. So we kind of wanted to use that expertise to bring omics into the field of food allergy and particularly Fpies. And so the aims were first and foremost to investigate the biological mechanisms underpinning acute Fpies with the aim to identify diagnostic and prognostic biomarkers using a multi-omics approach. But then we we established partnership with 12 centers in Spain and now 4 centers in Italy as recruiting centers, and recruiting, a large number of patients from those centers will help us assess the clinical characteristics of a large European patient cohort of Fpies and what the implications of those characteristics will be to help improve diagnosis and management of acute Fpies. But we also early on wanted to understand the patients and the families' challenges and unmet needs to help co-design strategies for clinical improvement and research. And these are the publications so far, some very clinical coming directly from BioFpies and some other collaborations within the network as well. And these are the recruiting centers together with Imperial. So when we go about sort of diagnosis and management of Fpies, we have the key reference document for that many of you will be familiar with. So the 2017 International Consensus on Fpies that covers all the different aspects. But it's been a while since that was published, and now there are a number of narrative reviews and sort of expert opinion papers touching on some of those aspects, and I'm going to reflect some of those as I go along as well. So we're going to start with case scenarios, okay, just to bring it back to clinic where we all see it sometimes, some days of the week, right? So this is a very typical case of more severe Fpies that we see. So baby Anna, 5 months, exclusively breastfed, has tried formula 3 times as mom is back to work within a week. And then the last time, after the 3rd exposure, 3 times later, she had violent vomiting 4 or 5 times, went extremely pale, floppy, and sleepy. An ambulance was called, and she was given IV fluids and IV antibiotics. She slept for 3 hours and then fully recovered, and she had slightly runny stools for 2 days. Sepsis screen was negative. She was labeled as acute gastroenteritis, was given antibiotics for a couple of days, waiting the cultures, and then was discharged home. And then a week later, she tried Casmet formula again, and she had exactly the same symptoms. She has not been weaned into any solids, and parents are extremely worried about introducing the new foods because for them, the first thing they tried, they had that horrible experience, okay? And then another case that could be Fpies, quite different, okay? So baby Max, 7 months, given cut for the first time, and an hour and a half later, vomited 3 times and had runny stools that day, recovered at home, and he attends nursery, and parents thought that would be just mild acute gastroenteritis, and they didn't seek medical advice at the time, and just when they went to the GP for another thing, okay? Mixed fed from birth, eating already fruit, veg, rice, wheat, and the family is pescatarian, and they're not worried about allergy. So you start to see how families, even with the same condition, of course, will have very different perspectives, very different needs, and we're going to have to target what we do accordingly, right? So I want you to think about, these are the things we're going to be talking about. So what are the priorities with these cases when you see them in clinic? How do we prove or disprove the diagnosis? Would you do any tests in clinic? Would you give them an action plan? And if so, how does it look like? And what's your advice regarding weaning or food introductions? Will you introduce everything? Will you introduce everything at home, or will you hold with any foods? Would you try anything under supervision? So we're going to discuss that. And then when it comes to trying the culprit food again, how do you do it? When do you do it? So we're going to go through that and look at what the evidence is and what we've learned from BioFpies as well. So what are the priorities? So if we look at what the priorities are more for the community, the whole community of Fpies, so we ran this global survey a couple of years ago on parents and adults with acute Fpies, and the top 5 priorities were very much about improving diagnosis and prediction of tolerance. So you see the top 2 there. It's very simple, improving awareness amongst healthcare professionals and medical students, because patients and families face a lot of misdiagnosis, a lot of lack of knowledge about the disease, and if you don't know about the disease, you're not going to be able to diagnose. So there's a lot of delay in diagnosis, a lot of misdiagnosis that makes it a very tricky journey for many families to get to the point where we know where they're at and what needs to be done. Okay, and then the other 3 key priorities are about test to predict resolution, test to predict safe foods, and test to diagnose Fpies acutely. So it's very much, you know, diagnosis acutely to avoid misdiagnosis, but then once they have the diagnosis, they want to don't do challenges, they want to test that tells them, is this food okay, and is the allergy resolved, and can I reintroduce that safely into the diet? So that was very interesting to see and help us decide, you know, where we go with the research and the clinical initiatives. So going back to knowing that, going back to our cases, so what do I think are the priorities for this baby? So establish the diagnosis, and we will see we have a typical presentation with the key reproducibility aspect in food allergy. So you have very consistent presentations on the 2 last occasions has been exposed to the food. So to me, that makes me very confident this is food allergy and specifically acute Fpies. So we're going to be issuing a personalized action plan. We'll see how that looks. And this is, you know, one, to help the family know what to do if a reaction happens by accident in the community, how to approach it, how to or when to seek help, but importantly also to support that emergency care in A&E where they might go and people have never heard about Fpies or not know what sort of specific treatment that might need. Okay, and then we're going to advise on a weaning plan and support the family throughout, and then explain the expected prognosis and how we're going to be supporting the family for follow-up. For the second child, we'll argue that most children presenting that way, they're not Fpies, there's something else. They're acute gastroenteritis, or who knows what happened that day, right? So first disprove or disprove the diagnosis, and for that we're going to have to try the food again. So if you, I mean, I would say it's more elegant to do that under medical supervision, because you can, you know, have another reaction, of course, if that's Fpies, and the reaction could be worse. Okay, so, you know, retry, so challenge, diagnostic challenge in that specific instance, which is rarely needed in Fpies, because by the time patients come to us, they often have had more than one reaction to the same food, and therefore, you know, you have the reproducibility aspect. So how do we go about diagnosing Fpies? So Fpies diagnosis is not easy. It might be easy for us as pediatric allergy specialists, pediatric gastroenterology specialists. We think about it, right? We know about it, but there's very limited awareness outside allergy specialists and their publications on that. And at the end of the day, what happens is that when people think allergy, they think immediate, they think skin, they think respiratory symptoms, they think typical foods, and Fpies doesn't meet much of that, right? So it's a very gut presentation, plus minus systemic compromise. So you have repetitive projectile vomiting as the key feature in children, often with pallor, with lethargy, with floppiness. So up to say 70-90% of infants present that lethargy, floppiness, relatively often diarrhea, and up to 15-20% go into dehydration and hypertension and shock. Okay, so it can be a life-threatening disease, and then you can have some other complications there. But you know, there's no respiratory symptom, there's no skin symptoms, so it doesn't look like an allergy, right? The timing is delayed, generally 1 to 4 hours post-ingestion, but the time frame can be much broader. It's relatively rare compared to IgE-mediated allergy, but not rare. So the cohort study showing an incidence of 0.7% in the general population. And again, you know, your typical foods, I mean, of course, it depends on which part of the world you're in. I'll be very interested to hear what are the typical culprits in India. So typical culprits sort of across the world, particularly English-speaking countries, so milk, fish, egg, but also unusual foods that people don't see as allergenic, like rice or oats or vegetables or fruits or chicken, etc. Your allergy tests are going to be negative, as we will see. So people think, well, if the allergy test is negative, how is this an allergy, right? Well, this is not IgE-mediated, of course. And the allergy drugs, your antihistamines or adrenaline, is not going to be effective. So again, that doesn't look like an allergy, right? So there's no diagnostic test. It's going to be very much a clinical diagnosis where you need to be aware of the typical presentation and recognize it as such. So it needs that clinical suspicion to start with. Without that, you're not going to make the diagnosis. But at the same time, the differential diagnosis is broad and complex. And often you're talking about very sort of acute emergency presentations that need very clear, very emergency treatment for the patient to get better. So you have sepsis, septic shock, you have acute gastroenteritis, potentially with dehydration, you have anaphylaxis when there's no skin or no respiratory symptoms, you have seizures, you have cyclic vomiting, you have certain metabolic diseases, you have abdominal causes that might need surgery. So all of that comes into the differential of Fpies. And of course, I will never question, when people are treated acutely, these things, of course, first comes first, but when patients have had 3, 4, 5 episodes, we need to think something else, we need to think Fpies. So there are diagnostic criteria for Fpies. Again, this is very much consensus-based, and this is the sort of the best accepted from the 2017 consensus. I guess the problem with that is that they haven't been validated in patients outside Fpies. So no study has been done trying to see how this fits in the pool of patients that present like Fpies, but might not be, okay? And therefore, you don't know about sensitivity, specificity. So you've got there, you need to meet major criterion, which is your vomiting 1 to 4 hours after eating the food. Time frame can be broader. And then 3 or more of the minor criteria, and you see them there. So second episode of vomiting to the same food, or episode of vomiting to a different food, because up to 30% of patients might have multiple food Fpies. Extreme lethargy, marked pallor, emergency attendance, IV fluids needed, diarrhea, hypertension, hypothermia. Okay, great. So what's the problem with that? So it's like if you go to A&E because of acute gastroenteritis and you have vomiting, you're pale, you need fluids, you have diarrhea, you meet criteria for Fpies. Okay, so that's a big issue, right? So how do our patients meet or don't meet criteria? So baby Anna meets the major criterion and meets the 6 of the minor criteria because he got very, quite severe. But if you think about baby Max, it only meets major criterion and minor criteria. And you'd say, yeah, it's quite unclear. But if you challenge him, he will have exactly the same symptoms. And you run the criteria again, and still he doesn't meet the 3 minor criteria. Why is that? And we saw that with BioFpies when we started. 1 in 4 of the children we recruited, they've had multiple vomiting episodes to the same food, so separate episodes, but they wouldn't meet criteria because they were just mild. They wouldn't get bad enough to meet 3 of the minor criteria. So to me, this is not that it's not Fpies, it's mild Fpies. And I think the more we know about Fpies, the more we see that patients react with different sort of levels of severity, okay? And mild will be say, this is based on the consensus, mild is 1 to 2 episodes of vomiting, no lethargy, and no features of a severe reaction. And you see the features of severe reaction there, which are all quite common sense. Severe lethargy, hypotonia, floppiness, cyanosis, hypertension, hypothermia, etc. Okay, so be aware of the different sort of spectrum of severity. Okay. So the other thing we know now in the last 10 years have been, publications about Fpies in adults is a bit of a new phenomenon. And a key thing is that up to 40–50% of adults with acute Fpies don't vomit. They might have nausea, but they might not end up vomiting. And they have abdominal pain as the key feature. So how do your criteria apply there when, the major criterion you have to meet is not met, okay? And that took myself and my colleagues in Soles from Spain to write some amended sort of diagnostic criteria where vomiting was the major criterion, but in typical presentations in adults, abdominal pain could replace vomiting as the major criterion. And then reproducibility for us was key in a way that if you had a second episode of vomiting to the same food, you will reach 3 points, and you needed 3 points rather than 3 separate criteria for that, okay? And we made other considerations based on what we learned from Fpies, such as neutrophil increase, counting, abdominal pain counting, nausea counting, because are very, very common. And new medical algorithms, both in adults and children, both diagnosis and management, have incorporated some of these aspects just to reflect sort of the spectrum of Fpies presentations beyond sort of the initial criteria there. So do we do IgE testing when we see patients with Fpies? Okay, so if you go to their consensus, the advice is a bit sort of ambiguous there. So you see IgE should not be done routinely, but perhaps before milk challenges. And they say that it might reflect a more persistent Fpies course or a switch to IgE-mediated allergy. And the more we know now, you know, and there's new knowledge in the last sort of 5-7 years about mechanisms of Fpies, IgE is nowhere to be seen in the pathophysiology. So you wonder, are we looking at the wrong test? But more recent sort of narrative reviews and expert opinions are even reflecting more and more of a role of IgE testing in Fpies, both at diagnosis as well as at follow-up, and suggesting that patients with more atopic backgrounds might have more common sensitization to the culprit food. And that's coming in new algorithms when deciding how to do challenges in Fpies. So we wanted to check the evidence to really see, okay, what can we learn from the published literature on the role of sensitization to the culprit food in acute Fpies. So we did this systematic review and meta-analysis last year, we just published, and we gathered nearly 2,000 studies, went through screening, and 53 were eligible, which included over 3,500 participants. And we had very clinical questions for this, like you sitting in clinic, like how common is to be sensitized to the culprit food when you have acute Fpies? And the rate is 9.8% of your patients, okay? But that differs per food. So egg and nuts give sensitization much more commonly, over 20%, okay? And these are the very foods that are reported as emerging or increasing culprits of Fpies in infants, coinciding with a change in, weaning advice for early introduction for early food allergy prevention purposes. Okay, so quite interesting finding there. Milk is about 13%, and then other foods are much less common, to give sensitization, so fruit, fish, vegetables, etc. Okay, so it varies per food. The other question we had was like, okay, how common is seroconversion? Meaning, if you test someone at onset of the disease and they test negative, how likely is it that they're going to turn positive over follow-up? Meaning, do I need to test over follow-up? And that seroconversion rate is 1%, but for milk it's about 5%, so it's higher. And then at the end of the day, we had, it's like great if you sensitize, but what does it mean clinically? So does it mean that you're gonna change to an IgE-mediated phenotype when you've started as acute Fpies? So we call that phenotype switch. And that happened only in 1% of your acute Fpies patients, 3% if it was milk. And then if you focus purely on the sensitized patients population, and we're talking sensitized to the culprit food, not sensitized to say anything else, that's 13%, which to me means that nearly 90% of patients with Fpies were sensitized to the culprit food. They're not going to switch to an IgE-mediated phenotype. So the allergy is either going to resolve or they're going to stay as Fpies. But again, that percentage is nearly 30% for those with milk Fpies who are sensitized, so more relevant there. And then the other question we had was like, okay, and is it being sensitized to the culprit food associated with having a more persistent Fpies course? And we found 10 studies with an analytical design addressing that question. 4 showed an association, 6 showed no association, and we couldn't see a clear trend or a group of studies being methodologically more robust than the others. So we couldn't come to any conclusions, and we couldn't do meta-analysis because of the methodological heterogeneity. And at the end of the day, I think, it's good to see the data there. I think we're looking at the wrong test. I think perhaps that it has more clinical relevance for milk. I don't think it has much clinical relevance for anything else. So, you might do the test because it's just so cheap, so easily available, but just be aware of the limitations and the limited clinical relevance of the test results, I will say. So moving on to management. So how do we manage Fpies acutely, and how do we plan, for potential reactions in the community? So The management of Fpies is very much, your research type management, with fluids that can be repeated as needed. So that can be done orally if the patient is really mild and tolerating, but the vast majority of cases might need IV fluids. Ondansetron is coming in to stop the vomiting. The evidence is very limited, and the best evidence comes from 6 cases published in Allergy in 2020. But I think it's very much coming into clinical practice and coming to the different reviews published more recently. And again, that can be given IV, but there are also oral preparation and sublingual film type preparations that can be really helpful in the context of vomiting. Steroids have been used. There's no evidence, and I will discourage against the use of interfering with the immune response that could be partly compensatory. So I think there's no evidence to support steroid use really. And some patients need to go to intensive care for inotropic support for mechanical ventilation. So it can be a life-threatening condition. As we mentioned, antihistamines, IM, adrenaline have no role. And then once you've recovered, so you have advised food avoidance, and many patients don't react to really small amounts. So often, they can have may contain labels, but some patients are exquisitely sensitive, and you have to be careful with even very small amounts. And then when it comes to trying very closely related foods, so say your chicken and turkey, for instance, or your wheat and barley, you either avoid the closely related food or you introduce that under supervision, because the chances of reacting are quite significant. So this is just to raise awareness that Fpies can be life-threatening. So no deaths have been reported as a result of Fpies as far as we know, but cases of cardiorespiratory arrest have been reported. And we had a case of, life-threatening Fpies going to intensive care due to cow's milk through breast milk, which is really exceptional. So most patients with Fpies wouldn't react because of the allergen in breast milk at all and can carry on breastfeeding. So this is how the acute Fpies action plan looks like. This is from the British Society of Allergy and Clinical Immunology, very recently developed. And I think it's very good because it's very visual, very clear. So it states, if things are mild, vomiting, tolerating by mouth, no floppiness, no lethargy, you can stay home, try and rehydrate your child. But if things look worse than that, you need to seek for help. And particularly if it's a severe reaction with repetitive vomiting, with marked pallor, hyperresponsiveness, etc. You put your child in a recovery position and you call the ambulance, okay? And again, it has a little bit about treatment in A&E to support the medical staff there. And there's some really good websites, good charities across the world, particularly in the UK and the States, about Fpies with really good resources for parents as well as patients, particularly when they get firstly diagnosed. So I encourage patients to go into the website and have a good look. So moving on to how we do weaning in infants sort of newly diagnosed with Fpies. So we have to acknowledge that there's limited evidence, and at the end of the day, you're gonna give individualized advice, and a lot is about how they, the family, and you deal with uncertainty and risk, and what's your best approach. And often you don't have good quality evidence in your region as to how common multiple food Fpies is, or what specific food associations you need to be looking at for, or how common is other types of food allergy in your population. So you're gonna make decisions with limited evidence, okay? But at the end of the day, our aims are to support families, support the quality of life, and particularly prevent wide restrictions due to fear of introducing new foods, which is not rare in the Fpies community. So we did this survey a couple of years ago, trying to understand how much of feeding difficulties there was out there in children with Fpies. And one of the questions we asked, we were interested in how that early experiences were for parents, how frightening they were. And we asked about how frightening it was, the initial Fpies reaction and weaning your infant with Fpies. And as you see there, most parents said extremely or very frightening. So they start off their journey like that. So I think that's to be taken into account. So 36% reported significant feeding difficulties, and only half had advice for that. Having feeding difficulties was associated with a greater impact on family life and well-being, and being extremely frightened or very frightening to feed their child was an independent risk factor for then reporting feeding difficulties. So that early interaction and sort of trauma might sort of determine how that relationship with food and feeding practices evolve over time. And parents suggested some advice and tools that might be helpful, so some work for us to do to support these families better. So at the end of the day, as I was saying, when you're thinking about, do I take any precautions about introducing new foods in the child, you're thinking, how likely is it that this child is going to have Fpies to a different food or have other food allergies that have not presented yet? And that's particularly relevant for young infants. So we did that study with our Fpies, looking at multiple food Fpies and looking at every other type of food allergy, and the results were consistent with other sort of more preliminary evidence from the Mediterranean areas of Italy, France, Israel, and we saw that only 5% of our patients with Fpies will have multiple food Fpies. So most of Fpies in Southern Europe is fish, followed by milk and egg. And it was the kids reacting to the uncommon foods of fruit, veg, meat, fish that will have multiple food Fpies, okay? And then, but that's different in English-speaking countries. So these are data from Australia, from birth cohorts, so you cannot blame them from having sort of selection bias and things. So 30% of children with acute Fpies had multiple food Fpies, including milk, with 44% of multiple food Fpies. And they also saw that those reacting to fruit and veg had more likely sort of multiple food Fpies. Similar data from the UK and US, although the data don't come from birth cohorts, they come from tertiary services generally, and more room for potential selection bias there. And there is this nice graph trying to find associations between foods, but as far as you can tell, is very much closely related foods because of probably the sort of the protein homology, the allergen homology there. So things like wheat and barley, chicken and turkey, etc. But some foods, being associated quite commonly, like milk and soya in English-speaking countries, but that's not replicated in other parts of the world. So at the end of the day, because of this relatively frequency of multiple food Fpies, colleagues have developed guidance as to how to do weaning in children with Fpies, and they've done these sort of tables where there is a column that is high-risk foods, which is very much foods that are typically linked with Fpies, so your milk, egg, fish, etc., rice, and then a column that is low risk, which is foods that rarely are linked with Fpies, and that comes very much from serious reporting Fpies culprits, and then you have other things in the middle, and then you advise your patients to start off with the low-risk foods, and once they've tried quite a few and feel comfortable, move on to the intermediate foods, and then the higher-risk foods. So if you think about our patients, so we have that discussion with the family, say in the UK, in Spain, because we know multiple food Fpies is rare, I trained in Spain, we will say just wean as per normal, and that's acceptable and goes well. But here in the UK, we have this discussion about potentially multiple food Fpies. We have a chat about lower probability foods, higher probability foods. And with this family, they prefer to try rice and egg under supervision for reassurance, but they were very happy to try the low probability foods one by one at home with sort of support from the dietitians every couple of weeks and sort of easy access if things went wrong. Okay, and she reacted to banana, but nothing else. So on paper, this is multiple food Fpies, this is fully weaned otherwise and doing very well. And this is just the whole package of advice we gave at diagnosis. So the culprit is cow's milk, so they need to avoid cow's milk and dairy. We gave her an action plan, we gave her oral ondansetron, which we're starting to do, particularly in severe presentations, and we signposted to the Fpies UK website. We support breastfeeding no matter what, and no maternal exclusions are needed. She didn't have any symptoms in that week in between the two episodes, being fully sort of breastfed with normal dieting mum. And then if you need formula supplementation in a case like that, you can do extensively hydrolyzed formula, but I will give the first sort of feed under supervision just to be on the safe side because the reaction was severe. Or if you don't want to take any risk, you can try an amino acid-based formula, but the implication for taste, etc. later on. So someone like baby Max, much milder presentation. So you confirm the diagnosis with a diagnostic challenge or reintroduction at home if you can't do that, or you agree that. And then you say avoid fish, and this is your action plan. Okay, I wouldn't probably give ondansetron in that case. In certain families, if they're very sort of high fish consumers, we might offer a challenge to alternative fish species, particularly canned tuna, because tolerance might be better for that, but a good proportion of patients still react to that as well. So that was the case here. They wanted to do the canned tuna challenge, but he reacted. So the advice was no fish and follow up. Okay. They did all the other introductions at home and it went very well. So I'm gonna move on hopefully quickly to challenges and how to reintroduce the culprit food. So when to reintroduce, so the consensus says at least 12 to 18 months after the last reaction, and you basically being guided by resolution rates published in the literature, but again, it's a data poor area in many regions, so you want this great survival curve, showing you when patients develop tolerance over time. And that's variable across countries, but also, many areas you don't have that level of data, and IgE is not going to help much. But I think what hasn't been discussed yet is how the initial severity fits into that, because I will be prepared to challenge earlier for someone with a milder reaction, but I will be very keen on waiting a bit longer in someone with a really severe reaction, because we know time is in our favor. Most patients develop tolerance over time, just need to, generally wait. And some patients, unfortunately, have a persistent course. They don't sort of develop tolerance. The other thing is, what happens when you have those more persistent patients that are getting to an older age and they've come to challenge a couple of times and they still react. So do you still challenge them every 12 to 18 months, or do you wait a bit longer because you don't have any data, like longer term in that sort of persistent cohort? Okay, so these are the kind of graphs you want to look at. So the top one is from Australia, the bottom one is from Spain, some years ago, and bottom line, if you put the evidence together, is roughly milk and soya Fpies tends to resolve earlier with about 50% resolution by age 3 to 4, and solid food later, so 50% by age 4 5, which to me means that if you challenge someone at that age, you're still going to have half of people reacting. So this is the kind of message you need to really give to the families, not like, oh, they're going to tolerate, because quite a few don't. And these are data from the different studies. How to challenge, so I'm going to try and be quick there. So dosing and how to do it. So if you look at the consensus of very common sense and accepted recommendations there, you do this in a medically supervised setting because you see patients can get quite unwell. Rapid access to fluid resuscitation, which doesn't mean that all your patients need to have a cannula in before starting, but you need to be able to put it in if things get tricky, and that's the key thing you need to establish before starting. And then prolonged observation at least for 4 hours and longer if the time scale for the reaction onset is longer in their particular patient. But then when you look at dosing and protocols, which where you need the nitty-gritty of that, right, to do a challenge protocol. So the consensus says there's a variety of protocols, and the most commonly recommended and used is this protocol of 0.3 gram of protein per kilogram with a maximum of 3 grams. So if you are 10 kilos and above, you go with 3 grams, and you split that dose into 3 equal doses, say 1 gram or 1 gram, and you give that full amount over 30 minutes. In 30 minutes, you're done, and then you observe for 46 hours. So what issues do I see with that? So mainly 2 issues. So this is the gram per protein is very impractical, both for high protein and low protein foods, because you end up with a portion that is not an age-appropriate portion. So say in Fpies, you have quite a lot of high protein foods as culprits of egg, fish, where 3 grams is a tiny amount compared to an age-appropriate portion. And then low protein foods are more rare, like fruit and veg, where 3 grams is a massive amount that is way above an age-appropriate portion. So it's not really practical. So things are moving to base challenges on age-appropriate portions. But the other concern is more of a safety concern. So say, if you're talking about a disease that takes at least, generally 1 to 4 hours to present, if you're giving a full dose within 30 minutes, what if your patient didn't need that much to react? Are you contributing to severity? And we wanted to learn from literature to inform decisions as to how we should be challenging in Fpies. So we did this systematic review a couple of years ago that we just published as well. So trying to describe the OFC methodologies and clinical outcomes, but with the key aim of identifying challenge features that could be associated with better safety and better diagnostic performance. It was a painful systematic review, I have to say. So 51 papers, survived screening, great heterogeneity in methodologies and outcome reporting, paucity of data in certain areas. So we couldn't do meta-analysis, but we did narrative synthesis, and I'm bringing the key data, I believe, that help us inform how we should be doing challenges in the future. So the few studies that had given a relatively small amount and wait long enough to say they had given 25 to 30% of an age-appropriate portion and waited for 4 hours had over 70 to 75% of patients reacting to that amount. So that to me means that in Fpies, you don't need a full portion to react. The vast majority of patients react to less than that. You just need to give them time. And we saw, in the different protocols where that could be assessed, that over 50% of patients need at least 2 hours to react. Okay, so you need to give them time if you give increasing doses. And then our key question was, does dose matter for severity in Fpies? Can we learn from studies? So there were no RCTs, no prospective head-to-head comparisons of challenge protocols looking at this, and there was quite a lot of heterogeneous reporting. But there were 2 studies, one from our Fpies cohort with 100 symptomatic challenges, and then a study from Infante from Spain on fish Fpies, and basically same conclusion in both. So they compared a protocol where in one day you give increasing amounts up to a cumulative of an age-appropriate portion versus a 2-day protocol where on day 1 you give 25% of an age-appropriate portion, wait for 4 hours, and if the patient doesn't react, you bring them the next day and you give an age-appropriate portion. And the 2-day protocol was associated with a lower rate of severe reactions. And when we did multiple regression, we only found the 1-day protocol, as the independent predictor of having a severe reaction at challenge. So how you challenge matters for severity, and probably it's all down to the dosing that you give in that encounter. So this is the protocol from Imperial NHS capturing that evidence. So we do now for most of our patients 25% of an age-appropriate portion. We wait for 3 hours rather than 4 because otherwise we run out of time, unless the time scale for reaction is longer, and then we give the full portion. And so far so good, but we have a few caveats for the very special severe patients, etc. So there's kind of controversy now in the literature just from this year, mainly from papers coming from the US about starting to do home challenges for Fpies, and that's coming to algorithms and what sort of conditions need to be met for that, which is very much not having had a severe reaction previously, and some guidance as to how to do it. And I guess, it kind of got me thinking, like, am I comfortable with this? And I don't think I'm comfortable with this. I mean, of course, I think there is room, and it's always a decision with the family, but I don't think we should just jump on it, with the evidence we have at present. So this is a bit of an exercise for me thinking, what would I need to see to feel comfortable doing challenges at home? And, one is sufficient evidence of challenges being done at home, and that's not the case because, in our systematic review, we saw that all the studies had done the challenges in hospital, or at least started. And the other thing is, I thought that most children won't react when you challenge them. But, say, for instance, in bio-Fpies, where we recruit patients with an acute Fpies diagnosis coming for follow-up challenges at the planned, appointment at 12 to 18 months, 1/3 react, and that's based on over 450 patients. So, and then is the thought that most children are mild or not severe, but that's not how Fpies presents. These are different series from across the world showing that lethargy, floppiness are 70, 90% of presentation, and in our Fpies we had 70% of the cohort meeting criteria at onset for a severe Fpies reaction, so they're not mild. And then the other thought is, if you're doing challenges at home, so, you're thinking, well, if there is a reaction, it's going to be mild enough that you can manage that at home, but that's going to be, purely a mild reaction because consensus and action plan says that if it is beyond mild, you're going to go to hospital. So that's 1 or 2 episodes of vomiting and no lethargy. So we've seen that that's not how patients present, but, and this is kind of the guidance as to what can be managed at home. So at the end of the day, if they're not mild, you kind of relying, say, on ondansetron to do the trick very quickly. So they stay as mild, okay? But the time of onset of ondansetron, including with IV treatment, is about 30 minutes. And the peak concentration is an hour and a half. So what have we learned from our Fpies about using oral ondansetron? So again, this is 81 positive challenges published last year. 82% of them got ondansetron. Only 11% ended up as mild. So, and this is children admitted to hospital, most of them with a cannula in, that at the point where you think, okay, this is a reaction, you start IV ondansetron. So it doesn't seem to stop progressing from mild to more than mild. Okay, so I'm not that comfortable just relying on that at home. And then, you know, it's like, can you predict that patients with a previous non-severe reaction are gonna be mild? Okay, so that only happened in 20% of our patients. And you can have all sorts of things. So people with a mild reaction going into moderate to severe, people with moderate going into severe, and people with severe going into severe or moderate, but they don't just all go mild, certainly, okay? Similar studies from Italy. And at the end of the day, previous studies have shown that based on the clinical characteristics you have, you know, from community reactions, etc., patients' characteristics, you cannot predict the severity of reactions in Fpies. So I think we need to be careful about home challenges. Not very happy with that. Okay, so this is very quickly. There are the consensus establishes criteria on how to assess the challenge outcome. They are similar to the diagnostic criteria. And from our Fpies, we learned that neutrophil increase is very much a universal phenomenon, but it's not just neutrophils that change. It's very much all the different leukocyte subsets that change, and mainly reduce rather than increase, and probably migrate to the gut. And we saw that the neutrophil increase is inversely correlated with the severity of the reaction, which we found very interesting. Outcome criteria might have limitations. We saw that about 20% of our patients with objective symptoms plus minus neutrophil increase did not meet criteria, and there were milder reactions, so a bit similar to milder patients not meeting diagnostic criteria. You might have patients who don't have, you know, don't tick all the boxes. So for me, these are likely positive, and be aware of the limitations of the criteria. And this is just to raise some awareness that you can have false negative challenges in follow-up challenges in Fpies. So that means you do a challenge, a follow-up, you have no symptoms whatsoever, and then the next time round they try the food, they have a full-blown acute Fpies reaction. We saw that in 1 in 8 negative challenges when we started with over 100 challenges, so that made us quite concerned. We've looked at the whole cohort we have now with over 150 participants, and it seems to be more like 5% of patients have a false negative challenge. So that's not a recurrence of the Fpies. That's very much, it didn't go away. It's just one intake might not be enough to trigger the reaction. Okay, so we might need to warn our families about this possibility, although it's not very common. So super quick on mechanisms. There have been really good papers published in the last very few years, very much using sort of data-driven approaches or mixed approaches. And this is very much what we know. Part of this is, say, hypothesis still. So there's no evidence for antibody recognition of the allergen. And there seems to be, you know, very much of a gut recognition, gut reaction. So allergen gets taken. The hypothesis is that the antigen-specific T cell that recognizes the allergen lives in the gut and attempts to identify that in the periphery, having been successful so far. And this T cell recognition will drive a Th17 response that will activate different types of leukocytes, particularly monocytes, neutrophils. And someone there produces adenosine that will stimulate the enterochromaffin cells to produce serotonin. That seems to be a key driver of the reaction through activating the vagal afferents and activating the vomiting center in the brain. So it's very much a gut-brain axis disease. And if you look at the functions of serotonin, you see that this explains quite a lot of your Fpies symptoms, with activating vomiting reflex, perception of pain, nausea, peristaltic secretion contributing to diarrhea, vasodilatation, etc. So no wonder why ondansetron might work for Fpies as a serotonin receptor antagonist. But I think, you know, we still don't understand very well the neurological manifestations and the cardiovascular manifestations beyond patients who are hypovolemic. Okay, and I think there's a lot of potential autonomic system involvement there. And what we don't know is, you know, is there an element of instability or exaggerated response in their autonomic nervous system in patients, particularly with severe Fpies. There's some studies now looking at the microbiome. So with Fpies, we've contributed to this as well. So we've done a whole exome sequencing analysis trying to identify genes and gene variants associated with Fpies susceptibility and pathophysiology. Published that last year, and is you see the genes there. I'm not going to go in detail, but it's all about epithelial barrier dysfunction and immune dysregulation. So very much common ground with other allergic diseases, right? And then we have 2 publications coming that we presented at TIACI on diagnostic signatures using transcriptomics in saliva, so a non-invasive sample, and then microRNA signatures with very good diagnostic potential in blood. And with that, I'm going to stop there. I'm not going to go through the summary in the interest of time. And thanks so much for listening. And very happy to have a discussion. So big thank you to all my collaborators, of course. And again, very happy to take any questions. I cannot hear you, Nandana, sorry.
I'm sorry, I was muted. Sorry about that. Yeah. So I was just saying, thank you so much. That was an excellent and really insightful overview of Fpies. And it was so fascinating to hear about the latest research and guidelines and get a summary of, the various protocols, example, the management, weaning, challenges, etc. And I found it particularly interesting about the concept of false negative challenges. And I can imagine that, when we have a false negative challenge, when we do an oral food challenge on these children, and they go on to have, a full-blown Fpies later, that would be, a very challenging situation. And in India, I think we see more single food Fpies rather than multiple food Fpies. But I would want to hear from Professor Shamina about that too. And I think the main culprit we would see would be cow's milk. And and also, really interesting to see your data on adult Fpies. That is, something new that has come up and quite fascinating. Would I would want to take up some questions, but before that, if that's okay, I would request Professor Shyam Meena to share with us some of his experience and insights into the Indian scenario regarding Fpies. I hope that's okay, Dr. Mata.
Uh, Thank you, Dr. Marta and Dr. Nandana. Especially Dr. Marta, such a wonderful, lucid, very informative session. You nicely cover all the things till the date. What are the research about the biological molecular level as well as role of the whatever other things, because we are the nowadays we are the facing the many issues regarding the overlapping FIs in which have the IG involvement is also in some of the cases. As we have the in India's majority of the cases, we have the cow milk associated FIs, but in the other one is after cow milk in the soya protein or wheat protein also additional factor that cause the food protein associated enterocolitis syndrome. Definitely, you trying to highlight about the home-based oral challenging, oral food challenging, but still in the India because we have the lot of the issues regarding the awareness of the health. So, as a gastroenterologist, I don't want to advise to my patient to home-based oral food challenge test because they need the highly proper education about the disease background as well as possible complication, and still we have the some health facilities slightly still far from the patient living areas. So definitely that is one of the important things to clearly explain the parents about the possible adverse effect and outcome of about that reaction. Over to Dr. Nanda.
Thank you, Dr. Shams. So I completely agree with you that in the Indian context, we are very wary of suggesting home reintroduction of these culprit foods. So I think for our scenario as of now, I would certainly be much more comfortable doing it under supervision in the hospital, with all the resuscitation facilities available. But of course, I understand that in Western setup or in developed countries, the scenario may be slightly changing as of now. If it's okay, I would like to take some of the questions. Dr. Mata, would you mind if we took some questions?
No, very happy, very happy.
Yeah, thank you. So one of the questions is, what's the likelihood of children with Fpies having other IgE-mediated food allergies?
Yeah, very good question. So there are not many data there. We looked at that in Fpies, and it's less than 10%. So it's something like 8%. So it's not really that common. And of course, other atopic diseases are more common in children with Fpies compared to the general population. But it's not, often with IgE-mediated diseases, you have the whole package. I mean, Fpies seems to keep a bit more sort of in isolation or with another disease, but not so much, your atopic sort of IgE-driven pathway, really. So I will say less than, say your EOE patients, for instance.
So I take it that it's not common practice to test these children for IgE to common allergenic foods. You wouldn't normally do that. Okay.
No, I generally wouldn't do it. Yeah.
Yeah. Thank you. Yeah. The other question is, what's the earliest that Fpies can present? And is the diagnosis mostly clinical in children? I think you've answered some of that, but yes.
Yeah, so definitely the diagnosis is clinical. You don't have really any pathognomonic test. You might have increased neutrophils, but infection can give you that, stress can give you that, so not pathognomonic. So it's very much a clinical diagnosis. And I will say again, reproducibility is key, typical presentation upon more than one ingestion or related foods, etc. So what's the earliest? I mean, it can really present in the neonatal period, particularly when it's the cow's milk, and sometimes then the differential is more NEC, so necrotizing enterocolitis, sepsis, etc. And there's a very recent review from a colleague in Italy looking at neonatal Fpies as typical features that are not that common. And again, it can be missed because neonatologists are absolutely amazing, but allergy doesn't come up that much, particularly because they have so much of a preterm cohort where the immune system is just like not very reactive. So allergy doesn't come to mind as the first thing. So yeah, definitely from neonatal period. I think, if you're talking milk, Fpies very early on, first few months of life. If you're talking more solid foods, it's a matter of when the food gets introduced. Often is with the first few exposures, but it can be after quite a few exposures as well. So it's not like necessarily the second time, okay, but it's generally within the first few times, yeah.
So I just would like to, find out about your experience regarding Fpies in older children and adolescents. What is the trend that you see nowadays?
Yeah, so I think most of the older children we see and teenagers are patients where Fpies has not gone away yet, and they come for challenge and they react to challenge and they generally hate us because it's not the first time, and often that's when they want like to wait for 3-4 years, which is fair enough. So that's most of the patients we see. I don't see really much, new onset Fpies in teenage years, which is what the adult colleagues see, but it seems to be more towards sort of age 30 plus, particularly in female. They have newly onset Fpies, and most of that is persistent, but there's some transient disease reported as well. So I think we need to watch this space. I also think that a lot of older people with Fpies don't come, to see us because it's like, they think it's food poisoning, and only if it's happened 3 or 4 times, and they really want to eat the food, or, in certain regions of, say, Spain, where I come from, shellfish is the main culprit in adult Fpies. And it's so consumed that they feel they're missing out. So they come to say, is it just prawn or is it everything? Can I have everything, something else? But most people with Fpies starting, say, in probably early adulthood, they wouldn't seek medical advice. They don't see the point. They don't think it's allergy. They wouldn't seek allergy advice. So Yeah, so that's kind of our experience in say all the children. The impression is again very preliminary data. All the children might present a bit more like adults, so the abdominal pain is very prominent. You know, again, if you think Fpies was very much described in infants, where there's abdominal pain, they cannot talk, they cannot tell you. So the older child is gonna tell you, okay, and they might not vomit or not vomit that easily. And we saw that in the inconclusive challenges as well. So I think it's, a bit of a spectrum there. And, for me, what is fascinating is why the infant shuts down and goes floppy, lethargic, pale grey. And that doesn't seem to happen that much later on, So it's like, I think it's like the more we know about the autonomic response, I think the same stimulus probably triggers a bit of a different response at different ages. So, yeah.
Yeah, thank you so much. Yeah, and final question: do you think that the incidence of Fpies is on the rise? What is the impressions?
Yeah, I think we don't know because no studies have really compared incidence, say, based on cohort studies. I think definitely publications have gone up, but that might be a matter of awareness and people wanting to share their experience, particularly in a disease where the geographical differences and wanting, to publish those data, which is fun, great. I wouldn't venture to say incidence has increased because it could all be, down to awareness and recognition. I think, studies need to be done, comparing sort of birth cohorts where it's been done already and not. I think my colleagues in Spain, where, it's a well-established disease, I don't think they have the feeling is increasing. I think people agree peanuts and egg are increasing. And I've discussed that with colleagues in different parts, states, Italy, etc. So I agree that can be the case, and there's some preliminary evidence for that as well. So I think we need to watch the space.
Yeah, yeah. So I think with that, I think we have no more questions.
I have the one question for the Dr. Marta.
Sure, yes.
Dr. Marta, how you look about the availability of the various questionnaires-based diagnosis of the Fpies? Because still we are so far from the validated questionnaires about the Fpies.
You mean the diagnostic criteria?
Yeah, diagnostic criteria. Along that, various non-validated questionnaires are available. On basis of that, they presumably make the diagnosis of the Fpi.
Yeah. So, for BioFPIes, we go over the consensus criteria, but we have the adapted criteria. So we say you meet either or, because again, I think for me, it's the reproducibility aspect and the typical representation aspect that is key. And I think that automatically increases your specificity. Say so someone wouldn't have 3 episodes of acute gastroenteritis just after the same food. You know what I mean? So for me, that the food culprit, the cause effect has much more weight than whether you go pale or not, or you go lethargic or not. That often is difficult to elicit in kids because they might fall asleep and it might be nap time, or was it nap time? So I think the reproducibility aspect. So I would say good to be guided by criteria, but I don't think they are set in stone or don't see that as your test. I think your clinical judgment is much more of your test in a way.
Okay, and last question, as a allergy specialist, how you look the role of the endoscopy in the Fpies?
Yeah, I don't think, honestly, for acute Fpies, there's a role for endoscopy. It's a very acute presentation. Patients recover really well. So I think, as much as I would like to understand the pathophysiology in the gut and take samples in the gut, I don't think that makes a difference or helps you in decision making at the individual patient level because the treatment is going to be avoidance, and yeah. So, it's probably very different to other more chronic presentations where you want to know like more the type of inflammation, rule out other diseases, IBD, celiac. This is very much a healthy child that has very acute presentations if they're exposed to the food and then they recover, they go fully back to normal.
Because eosinophilic GI disorder is one of the upcoming challenging issues for the pediatric gastroenterologist. That's why I'm asking that question.
Yeah, I think, I didn't touch on chronic Fpies, which is a completely different sort of ball game. When you have chronic symptoms of repeat exposure and then the acute Fpies phenomenon, I still am not convinced that chronic Fpies in that context is a different entity from food protein-induced enteropathy or, the broad sort of eosinophilic gastrointestinal disorders. I think we need to understand much more the histology and the clinical presentation and all the differential presentations. So we're doing it now a systematic review on chronic Fpies just to understand how people are using the terminology and what's the evidence of that being a distinct entity, both clinically and histopathologically. So I agree, when you start getting chronic symptoms, of course, scoping might have much more of a role. But if you're talking pure acute Fpies, I don't think these, yeah.
And how you look the role of the biologics in upcoming in future?
Yeah, so I guess, again, acute Fpies, I don't think for now there's a role for a biologic. So
Or chronic?
yeah, chronic. Yeah, again, I'm not convinced chronic is a distinct entity. I think we need to understand pathways. And again, if you have the pathway very well characterized and you cannot exclude the food, because one could argue, if it is a matter of avoiding one food, two foods, do that, right? Rather than a biologic that is going to work whilst from the biologic and can have side effects. If you're like quite stuck with multiple avoidances, etc., and you know the pathway and you have the biologic, then why not? But I think we're far from that in non-IgE. I don't think it's going to be as clear cut as with IgE pathways.
For that, we need the more clear pathophysiology before going the biologics.
Yeah, definitely. Yeah,
Thank you. Thank you. Thank you, Dr. Marta.
Oh, lovely.
Thank you. Thank you so much for sharing your experiences and giving your valuable insights. I think if it's okay with all faculty, we can, draw close to this session. I hope that's okay.
Yes, yes.
Yeah. Thank you, Dr. Sham.
Thank you, ma'am. Thank you,
Thank
Dr.
you.
Anna. Have a good day.
Yeah.
Thanks
Thank you
so
so
much,
much. Thank you,
everyone.
Dr. Marta. Thank you, Dr. Sham and Dr. Neeraj. I think we had a wonderful session. And thanks to all of my dear friends and colleagues who joined us tonight. So on behalf of all of us, very good night to all of you. Thank you.